All right, I'm going to go ahead and get started. Hi, everyone. My name is Jazz Carr. I am your moderator for tonight's event. I'm a current third-year internal medicine resident at Case Western Reserve University in Cleveland, Ohio, and pursuing fellowship in hematology oncology. I also have the privilege of being a Capello Fellow at Doctors for America, and I'm excited to be hosting our January Advocacy Grand Rounds event today. Before we get started, I did want to take a quick minute to invite you officially to join Doctors for America and DFA to fight to improve healthcare access for all. We're a movement of over 40,000 physicians, medical students across the country who have come together since 2009 to ensure that everyone has access to equitable, affordable, high-quality healthcare and the opportunity to lead a healthy life. Becoming a DFA member is easy. Just go to the link in the chat to support DFA's work to improve healthcare with incredible programs like the Advocacy Grand Rounds that we're hosting today. I believe some of the links we posted in the chat by our DFA staff. A few quick ground rules before tonight's event. We will be live streaming the presentation to Facebook Live as well as recording it, and all materials will be available afterwards. And we welcome your questions. Please use the Q&A feature on Zoom. We'll address your questions during the second half of our session. And also we'll look out for comments in the chat as well. And now onto our speaker. We have Dr. Stacy Doucette-Sena today. She is a professor of health policy and Ingram Professor of Cancer Research at Vanderbilt University School of Medicine, Department of Health Policy. She is a health services researcher focusing on the intersection between health policy, epidemiology, and economics related to prescription drugs. She's been recognized for her work at a national level, advising congressional committees and multiple government agencies on prescription drug legislation, and being selected to serve on the Medicare Payment Advisory Commission in 2021. We're super excited to have you today. I hope you guys can all see Dr. Doucette-Sena's slides. Please comment if you're not able to, but I will hand it over to her.
Thank you so much. It's a pleasure to be here with you this evening. I'm going to do a quick overview, just a few slides to do a little bit of level setting around prescription drug coverage and access. Probably a lot of things you already know or have heard about, but I just want to reiterate some of the challenges that I think that we are facing now and will be facing in the near future and in the long term as well. So to get started, I wanted to first touch on how people are feeling about their health insurance and what they have to pay for both when they see doctors, when they fill prescriptions, and what they're paying for premiums for health insurance. And I thought this slide was particularly useful because it asks adults about how their ratings of these as being either fair or poor across all of these different health insurance types. And you can see that most people are not super happy with their health insurance, depending on which payer we're talking about. We're talking about people who've rated aspects of their insurance coverage as fair or poor. So this is pretty bad. You can see that across all insured adults, people are not all that thrilled with their out-of-pocket costs for prescriptions, for visits, and for premiums. But one thing that I found that was surprising to me is that this is, a pretty high percentage, even in the employer-sponsored insurance market, where we have a lot of younger people insured and a lot of people who get benefits through the ACA, like free preventive services. So it was a little bit surprising to me to see that even a group that we've historically thought about as being quite well insured is pretty unhappy with health insurance coverage. It's not all of the people, it's not even most of the people covered, but it's a lot of people who are reporting pretty unfavorable ratings around the affordability of their care. Now, we noticed too that among Medicaid enrollees, we see a lot more people who are happier with their care, at least relative to some of the other groups. And I think it's important to keep this into context is that this can change and is likely to change quite a bit for people, especially for adults in the Medicaid program. So this is an example of Medicaid enrollment and disenrollment for a lot of people since the coronavirus pandemic has been ended and as people are being reassessed for coverage eligibility. And we know that there are risks of people who are eligible being kicked off of coverage due to administrative errors or them just not basically getting or filling out paperwork to be able to access the benefits that they are eligible for. So there's a lot of concern around people even just maintaining their access to coverage. And, you know, we also have concerns about like just how much that coverage costs. So this is a snapshot of what's going on in employer coverage for the total premiums. And I always find this to just be like absolutely stunning when I see, when we're talking about a family contribution on employer-sponsored health insurance plans in the US, the average family's plan now costs almost $27,000 between the worker and employer contributions just for premiums. And this is not necessarily for the most generous coverage. These plans typically have fairly high deductibles, a lot of cost sharing, and still we're hitting these price points. They're just absolutely staggering. And this has been after a long series of years of growth in premiums, but not as much growth in workers' earnings. So you end up in a situation where people really don't feel like they're making more money over time. And in fact, they might not be, because a lot of those potential gains that they would have had through additional pay increases haven't been coming through. They've been eaten up in some ways by employers shouldering more of this premium increase. And if you've listened to news, I actually have been somewhat off the news the last couple of days, but I know the ACA marketplace credits is a huge concern, the stability of people being able to buy their own health insurance outside of an employer-sponsored plan. And this is an estimate from KFF about how much dollar increase an individual plan on the exchange would see depending on their household income, without those tax credits being extended. And this, of course, is much worse if you look at family coverage. Family coverage, the dollar increases are about 3 times as much as those that are shown right here for the individual coverage. But basically, it creates a scenario where people are going to have more challenges affording health insurance coverage, not even affording like things while they're on a plan, but even being able to afford to get into a plan. So there's a lot of concern around how much money we spend on healthcare services and prescription drugs, because it actually comes back and hits consumers directly as we think about their need to pay for health insurance and health insurance premiums. So it's something that we all should be thinking about, as the cost of healthcare services and how that affects people's ability to even be insured. So in the prescription drug space, there have been a lot of announcements over the last couple of months around prescription drugs. And um, these announcements are chaotic and typically fairly unclear and even inconsistent between the details that are written down and what is being announced. This is an example from one of the drug manufacturers' meetings at the White House to announce this big deal that they were going to agree to lower their prices for drugs in Medicaid to what they call the most favored nations prices, and that they were going to offer lower cost access to drugs like weight loss medications. An analyst that I really like a lot posted this great comment on LinkedIn that said, there's no reason, the reason you were all confused about what the price would be is because there were 22 different prices mentioned in this brief announcement, because the price depended on whether you had insurance or who your insurance payer was and which drug and which dose. Is it the first time you fill it or is it the next time? Which is just chaotic. Now, one of the biggest focus areas, or there are two, but one is related to international prices and what the U.S. pays relative to other countries. And I think it is important to recognize that we do overpay relative to our international peers. And this is an example from a couple of years ago through KFF and the Health System Tracker, showing the price paid for Ozempic at the diabetes dosing. And you can see that prices in most of our peer countries, list prices, these are not including rebates, are about $100 per fill versus in the US, they're closer to $1,000 per fill. So we know that we pay more than other countries, but I think the question is like when we hear about these deals to try to get most favored nations pricing, for example, what should we expect as consumers? What should we expect for our costs? And the truth is that we're not still close to paying $100 for these drugs. They're still far more than that. Even cash pay prices that have been announced are about $350 per fill. But it's better than 1,000. So we, the US, are number one in pricing. We would like to be a little bit closer to our peers, but I'm not sure that the current policies that have been proposed are going to get us to that level. Nevertheless, there has been some progress on reducing cost or negotiating prices for this drug through both the Inflation Reduction Act provisions, but also through additional deals, which are voluntary agreements that the White House has made with these individual drug makers. So we don't know all of the details, but we do know that, for example, in Medicare and Medicaid, these GLP-1 drugs are being offered for $245 for states and Medicare Part D plans that decide to engage in a CMMI demonstration project. So $245, that's a big change. But it's not actually so different than the price that was negotiated under the Inflation Reduction Act for Medicare. So to be debated a little bit about how much savings there are with these secret confidential deals. I also want to acknowledge that, I start by talking a little bit about the pressure on health insurance premiums. And honestly, when we think about drugs like the weight loss drugs, they are a huge consideration for almost every payer right now. This is an example of coverage that is relatively recent assessment for late last year, I believe, is when the last update of the data here were created. And it tries to give a snapshot of GLP-1 coverage by payers, state covered health plans, Medicaid, and Medicare, but Medicare doesn't cover these drugs for weight loss. And just to give you a sense, like the brighter pink, your plan or your icon is, the better coverage you have. But you can see states like Texas, where we have 34.4% obesity prevalence estimated by this group, and only 15% of covered lives have access to GLP-1s through their health insurance. Now, if health insurance expands access, one of the very significant problems is we're talking about a lot of people using a therapy that is chronically used, and it will have a significant effect on premiums. So this is one of the tensions that is in place right now. So when we think about access, especially to, high value drugs or drugs that we believe have a lot of benefits for people, another thing that the administration has been pushing is more of the cash pay market. Sure, you have heard of Trump RX, and I don't know if you've actually ever gone to the website to see it, but this is it. This is the front page of Trump RX, an official website of the United States government, according to the upper left corner. And this theoretically, in the near future, will be used to search for drugs that you want to obtain and will theoretically redirect you to a manufacturer's website or something like that, so you can purchase the drug at cash pay prices. So I think one of the things that I find to be a little bit of a tension here is this issue of trying to solve problems around pricing and access in the US by offering more cash pay options. I think one of the challenges especially is that cash pay options for drugs works incredibly well for generic drugs. So you probably are all familiar with GoodRx, Mark Cuban Cost Plus drugs. You have a lot of outlets that have very low cost generic drugs where you can purchase them without your health insurance, and sometimes that's a much better deal for you as a patient. For brand name drugs, though, this type of market doesn't really work well. So if you go back to the weight loss medications, sure, it's better than being asked to pay $1,000 per fill or $500 per fill, but is $350 per fill going to move the needle for most patients? The evidence out there suggests that it will not, that a lot of people can't afford to pay that amount of money every month. And I think we could kind of view this as a potential to actually make things a little bit worse on the spectrum of access. For example, I've had some friends and relatives. I get everybody tells me everything about their prescription drug benefits because they know I'm really into it and I'm like excited to hear what's happening. And a couple of friends have told me that their employers specifically sent notices in this last benefit year saying they were stopping coverage of weight loss medications for weight loss specifically because there were now more cash pay options available to employees. And so I do wonder a little bit about opportunities like this that are proposed as a way to improve access and what that actually means for access for people. Does it actually give insurers and employers and state programs kind of more leeway to take these drugs out of their benefit and push more people to pay their own cash for the therapies? And I find this type of setup that is being so heavily promoted to be of high concern because this is not just for one set of drugs. This is a program that the administration's pushing quite heavily to get more and more brand name drugs into, which I think could just further erode potential coverage. I hate to end on such a down note, but I know you guys are all going to help me to bring up the mood, and I'm looking forward to having a broad conversation. And I'm also happy to talk about any and all drugs, drug classes, anything that you have on your mind. So I'm going to stop there.
Thank you so much, Dr. Dusatsinet, for the informative presentation. I think you just, anybody's free, feel free to put any questions in the chat. I just kind of wanted to pick your brain about something that you kind of just mentioned. One of the questions I had was kind of regarding the commercial market and employee-sponsored plans and these private insurance plans and how they will respond to Trump RX. And I think you kind of hinted at maybe taking that access away from employers because there's a cash option now. Can you talk a little bit more about how you think that would further affect these plans from the employer side and the private insurance market? Is there any benefit of like maybe making it more competitive, or is there any upside that you can think of?
Yeah, like there are trade-offs here, especially for the weight loss drugs for specific indications. So I think, the Kaiser Family Foundation had a really nice set of surveys of employers asking them specifically about these drugs and how they're thinking about them. And so employers were pretty frank that they felt like they were important to cover. They felt like it would be a benefit that was in demand by people that they employ. But on the other side of that, they were like really scared of how much spending increase they were seeing for these drugs already. And so I think there's been a lot of conversations about like who's covered under the health insurance plan itself versus who's covered outside cash pay market. So I think there is some trying to distinguish between this higher level of clinical need versus lower level, which, it's really tough because our employers don't necessarily have the expertise to be able to differentiate that and to like work that through. But I think that is part of the conversation, is how do we differentiate? Now, one of the things that I've heard employers say is that the manufacturers have not been very willing to do that. So, for example, the state of North Carolina had provided coverage to their state employees a couple of years ago and then dropped coverage of the weight loss medications because they said they lost all their rebates when they tried to narrow the criteria for who could get access to them through employer-sponsored health insurance. Now, on the being an employee and paying premium side, there is a concern, like if the number of people who are eligible for these drugs started to take them, it would have a substantial effect on premiums for everybody in the plan. So I think that there is some kind of consideration of like who's the most appropriate would benefit the most and getting those drugs for sure to that group, but then being thoughtful about like, you know, that labeled indication is incredibly broad. So if you open it up to everyone, your spending is going to go really high.
Yeah, so I feel like in turn, it might actually lead to higher healthcare costs instead of reducing healthcare costs, which might defeat the whole purpose of this. So maybe not the more positive note in that sense, but I think that was really insightful though, because something you also mentioned was how Medicare Part D already gives a reduced rate. So I think that was another thing that was confusing to me about this Trump RX is how there's going to be an even further reduced rate, or how is that even going to be in, taken into account with this most favored nations pricing?
Yeah, this is where, as a researcher, it's incredibly frustrating because a lot of the policies that have been put forward, or even just announcements, right? So the initial announcements about the different pricing options, the details were not just limited, but in a lot of ways contradictory. So things said in the press conference versus things that were put in the announcement. And I found myself kind of looking to the manufacturer's statements on their websites because I was like, well, they have, shareholders, they have got to be technically accurate about what's happening. Um, it's incredibly frustrating though, as you're trying to compare and figure out what's going on. Even for the announcements that have been made and the detailed announcements coming out of CMMI, for example, or CMS about some of the models that they've put together to uh, get to international reference prices or most favored nations prices. I've talked to people who are closely involved in this, and they have said that it seems, and actually, Endpoints News reported this last week, that a lot of the deals that have been made with individual drug companies exempt those companies' drugs from entering the models that negotiate their price. So while it sounds like all of these drugs would have international prices, they would be lower, it turns out that all of these side deals are exempting most of the drugs that we would actually care to have prices negotiated for. So, as all things policy, the devil is in the details, and it's a shocking lack of details for some of the things coming out, or just, chaos.
I do have a question in the chat for you. So the question is, both United Healthcare and CVS/Aetna have vertically integrated clinical care and pharmacy systems. Why does this generate more profits for them rather than cost savings and efficiency for patients?
Yeah, this is really tough because if you talk with plans, they'll say, they've got all these firewalls and that there's not like talking between these intermediaries. But I think the reality is like there are different ways that companies can pay themselves and different administrative layers like that they can add between these different vertically integrated systems. So, for example, in the Medicare Part D market, MedPAC has done some work previously to show that when it's a vertically integrated Part D plan, like they actually overpay their own pharmacies relative to other pharmacies. So, like, if you are overpaying yourself, you probably have a chance to profit off of the different transactions that are happening in the prescription drug supply chain. And, you're allowed to make those profits, like, right? So you're taking those premium dollars and you get a certain percentage of them, but like the administrative and overhead costs get baked into that. So, I think it's just our entire system is built on this like every person for themselves or every entity for themselves, and everyone's trying to maximize profits. So they're kind of playing just within the rules that have been written. And I think that one of the frustrating things is like well, those rules aren't very patient friendly. And at what point do we all say this is like ridiculous? Like, do we really want $27,000 family premiums and for this type of not great coverage? It doesn't seem like a good idea.
Yeah, kind of along those lines. I think many of us on the call are, part of DFA or physicians in the clinical setting. What role do you think providers can play individually or collectively in shaping more patient-centered drug access policies?
Yeah, I always think so I've spent a huge amount of my time thinking about cancer drugs and access to cancer drugs. And in that space, there is a lot of low value use, right? Like there are a lot of drugs that are incredibly expensive and they really don't have the clinical data to back up those prices or even maybe use at all, right? Like very limited benefit for patients, maybe even just adding toxicity. And so, I have a lot of friends who are clinicians, and I'm like, well, you're the one with the prescription pad. So, like, that's a good starting place, right? Like, thinking about value, like, not, and thinking also about shared resources, right? So, um, I've done a lot of interviews with oncologists over the years, and, like, patient cost resonate very much with clinicians, but I've not found many clinicians who care so much about system level costs or like taxpayer costs. And I think that's important too, that we all think about this. I do think there's been a growing awareness of how unaffordable health insurance is. So, like, there's been a little bit more of an orientation towards, like, a lot of people can't afford basic coverage. So, like, how do we get to a point where everybody can afford some basic level of coverage? But I think awareness of value, your actions matter. And also, patients are exposed to a tremendous amount of cost. And so I think that trying to, it's like I know you have so little time, right? So, like, you really want the tools and you want the systems in place to make the decision easy. But there are so many ways that patients get tripped up around prescription drugs. One thing that we've learned from talking with patients and clinicians about when there's really high cost drugs is like prepping a person for that. So, for example, one thing we found when the doctors didn't feel like they could get totally accurate information out of like a real-time benefit tool. Just giving the patient the heads up that, this price might be different when you go to the pharmacy and Fizz, call my office. Like we can help you figure it out. Because we found that a lot of patients felt that if they went to the pharmacy and the price was much higher than what they thought, that they would just leave without the drug. And it's like, no, no, no. There are so many different ways to deal with that. And I think just like communicating that uncertainty and making sure that they know there's an open door back if there's a problem.
Yeah, I feel like there's a lot of confusion even from the clinician point of view in terms of pricing. So I can't really understand the perspective from a patient because I think it's probably much worse from them in understanding what the pricing of a drug could be. I think moving forward, you kind of mentioned this too. There's a lot of contradictory information in terms of the news that is coming out. How can we as clinicians like interpret these frequent policy announcements and like when these operational guidelines are still unclear? I guess it's kind of unclear how we can inform our patients moving forward if someone it does ask us like, okay, this Trump RX thing is coming. What does this mean for me and my drug prescriptions?
Yeah. This is one of the really painful points. Like I said, that announcement had 22 different prices. So it depends on like what fill you're on. Like there was a comment about all these news sites wanted to say it's $149 for the GLP-1 pill when it gets approved by FDA. And it's like, no, no, that's the first prescription of it, right? And then everything else after that is much more expensive. So how do you even translate that to your patient? It's like, who the heck knows how much it's going to be like from one fill to the next? It's like, it's just chaos. I think the things there that would be good, just like good rule of thumb. One is kind of knowing the resources that are out there to help refer patients to like people who can really help them with the insurance details and finding that lower cost drug. So on the Medicare side, right, there are SHIP counselors, the state health insurance program. Like every state has this independent group that can help people who are older adults to search for Medicare coverage. And those people are just like saints, right? Like they can figure everything out. That only helps people during like open enrollment, which is, October through December, but still good to know your resources. Like if I had a person who came to me and said, I'm using my Medicare plan and my drug is so expensive. Like you probably can't do anything for them in the short term aside from appeal, or change the drug. But then like pointing them to this resource for when open enrollment happens again, go back and like get that person's help to find a plan that helps you. For the weight loss drugs in particular, it's such a moving target that I think it's going to probably be a little bit of let's check these different places. Like, let's look at GoodRx. Let's look at this Trump website, which is supposed to coalesce everything. You can look at the manufacturers' websites as well. So if for example, like this patient, you would like to get started on this particular drug, you think it'd be better for them, go to that manufacturer's website if they're going to pay cash. And that's kind of like your worst case scenario. Because what I think patients need to be prepared for is if you go to your, pharmacy, you try to fill it and they tell you it's $1,000, that stop right there and go to these external websites and don't use your health insurance, because I think that's like the worst case is your patient just gets walloped with the usual and customary like not covered on health insurance price, and that just would be a total shame.
I think the difficult part of that would be what population of patients would be kind of, I guess, savvy enough to navigate that process, because even if they are paying this much money for their GLP-1s, maybe that is contributing to their insurance premium and maybe down the road would be helpful in terms of savings.
Yeah, so this one is the real tricky part. So I think figuring out like, is it covered by your plan and you're in a deductible? That absolutely pay with your plan. You're probably going to hit the deductible. For a lot of people, like probably a majority of people trying to use these drugs for weight loss. So most plans cover them for diabetes. A lot of plans exclude them for weight loss. So just weight loss alone. What they might experience is getting this high amount and it looks like a deductible, but it doesn't count towards your out-of-pocket maximums and deductible because it's a non-covered service. So I think that one is really tricky for people. Another thing would be to kind of keep tabs on the different partnerships that companies have done. So I think one of the GLP-1 companies has a partnership with Walmart to provide like one of the injectable or vial versions of the drug for a pretty low cost. So if a patient's probably not going to be able to get through all these different websites, you could say, okay, like, do you have this type of place near you? You could talk to the pharmacist there about getting it for cash. So there are some of those arrangements that I think are meant to try to help people who are not going to be comfortable going online.
Yeah, that's definitely helpful. I think there's a lot of different resources, but maybe we don't always have the time to maybe look into all of those.
Yeah.
I guess another question in terms of us practicing in this space of being able to get access for our patients, how can we continue to stay informed and adapt to these prescribing practices as the landscape continues to shift?
Yeah, I think, like a couple of things would be having a sense of where some of your key insurers are in your state, right? So, like the patients you see most often, if you, for example, know what your Medicaid plan is doing, right? So, if you see patients who are Medicaid insured in your state, understanding what type of coverage they have would be a good start. There are some public resources like the map and the data source I linked to there, which I'm happy to share those slides. They actually do show by state the current pretty current, what Medicaid programs are doing on GLP-1 coverage for weight loss. So I think just kind of having a general awareness for some of your bigger payers, you're not going to have perfect awareness. But like even having, your staff members or someone on your team do a test prescription to the pharmacy to see, okay, is this covered or is not covered? These drugs are expensive enough that like it would make a big difference, I think, if you really want to see your patient starting them to know like what's the starting place for them. And then, of course, the manufacturers' websites, I think, are probably still one of the better places to go because TrumpRx and these types of aggregators are just rerouting you to those places already. So they've set up some infrastructure to get the drugs to patients. And I think have built in some patient's assistance as well. So the price might be lower than that $350 price that keeps getting quoted. But it's such a moving target that this could theoretically keep coming down as there's more and more competition for prices around these drugs. One other thing that I think is important too is, like there are, although they're not as clinically effective, right? Like there's some older generic anti-obesity medications or weight loss medications. Like we've looked at a couple of different scenarios where people do have just less robust insurance coverage. So, like if you were thinking about a young person who's getting ready to age out of Medicaid and is now going to be on the insurance exchange or maybe uninsured, like thinking about low cost options that might help them if they've lost weight or maintain their weight loss. Um, I think you have to think a little outside of the box here. It's like the ideal thing you would like to be able to keep doing versus like the reality for that person.
Yeah, I guess keeping aware of what the options are and keeping an open mind of what is needed for the patient in that time. I guess beyond this, like the Trump RX and maybe the weight loss drugs, do you think in the upcoming year there are other coverage or policy changes that we should be expecting?
Um, it does feel a little Wild West out there with announcements, but I'm not sure that there's going to be anything substantial. I think I worry quite a bit about people losing their coverage altogether, right? The Medicaid churn, the issues around people and their subsidies. If the subsidies aren't available to people, those people will not be able to afford health insurance on the exchange. So you could end up with a lot more of your patients who just don't have coverage. On the flip side, there are the Medicare price negotiation for the first 10 drugs that were selected just went into effect in January. So, like, one thing that I'm kind of interested to see is like, do people taking those medicines see a big improvement in their ability to access them? I think we'll know more soon, but I think, that could potentially provide some relief to some people taking, some of the blood thinners and some of the diabetes medications. Um, so I think that you'll see a little bit of change for those patients. Maybe they don't get sticker shock when they go to the pharmacy. I know last year I heard a lot of people had a lot of trouble when they were going back in, getting their 90-day supplies and suddenly getting hit with co-insurance of 25% instead of a copay what they had been paying. So if that was the case, that group's going to see their price drop by about half because of the way the negotiations have worked. So hopefully some good news for the Medicare beneficiaries taking at least those drugs.
Yeah, I definitely feel like it's been difficult to kind of keep up with all the announcements and know how the drug prices are actually being affected. I think a great idea is kind of sending that test prescription and seeing what the cost might be before, just to give the patients a better idea of what it actually might cost. Um, I don't know if there's any other things that you wanted to touch on. I don't see a lot of other questions in the Q&A, but any other closing thoughts that you had?
Yeah, I think one other thing just to keep an eye on is changes to formulary coverage, right? So like health plans are trying to manage the pharmacy spending quite a bit. And so we are seeing a lot of changes in what's covered to what the extent that plans have the flexibility to do that. Um, and, that is very disruptive for patients, right? So, like, you go to the pharmacy and then suddenly the thing that you've been doing well on is no longer available in your plan. And so I think there will be quite a bit of that as people go into this next benefit year, um, just trying to figure out, like, how to get people on the drug that's best for them, or to appeal successfully to be able to get access to the drug that has been working for them. So I think that we'll probably see quite a bit of that going on as well. Um, I think in general, what you hope is that like the system starts to work better for patients, right? But in order for that to do so, like at some point, prices have to come down, whether through efficient generic or biosimilar entry or something else. But I think we're in an era right now where there are a lot of really expensive drugs, and in this case, many of them work incredibly well for people. So they're drugs you want people to have access to, but this is after years and years of spending a lot of money on drugs that are, kind of not the best value overall. And I think now we're getting to a point where we're going to have to start making some harder decisions or saying no to some things that are lower value or too high priced for the benefits they give. So you have more room in the budget to pay for drugs that are really helpful for people and might actually impact their clinical outcomes.
Yeah, I think an overall, another kind of point and question I had for you was, we're always told that the United States has the most healthcare spending, the highest cost of drugs. Could you give us some insight of why that is?
Yeah, we don't use our leverage as the biggest purchaser to get the best price. I think it's just, other countries are incredibly good at saying, like, we will walk away from this deal and you will not have access to our entire population. And part of that is that most of those other countries are under single payer agreement for the entire population. Um, and we instead kind of segment out all of our covered lives into these different payer arrangements. Some are covered by states, some are covered by employers, some are covered by Medicare. So we both don't leverage that size, but I think also just fundamentally there's disagreement about like, how much do we want to invest in innovative therapies? How much do we mind overpaying in some ways? And I think philosophically, Americans want all of the choices available to them. So like we don't like to have our choices limited as a group of people. So that is kind of fundamentally at odds with this idea of negotiating really hard and getting the best price possible. Because if companies know that you don't have the ability to walk away from a deal, you're not going to be able to leverage your negotiation and get the best price. Um, and I think, in some ways it's okay that the US pays more. Like you can look at very recent examples of how beneficial that has been for us for thinking about like access to COVID vaccines, access to the weight loss medicines when they're in shortage. Like who's getting those initial supplies of drugs? It's the highest paying customer. We're the first in line for new technology. But it also has a downside that, now we've allowed the system to kind of grow pretty unchecked. And we haven't really clearly outlined to companies, it's like more and more money, but like you should spend that money wisely so you incentivize the right type of innovation. At a certain point, we are going to have so many weight loss medications that, that come at the expense of actually trying to create therapies for diseases that don't have effective treatments. And so I think we have to think about how to put those incentives in place and pay in a way that encourages the right type of development.
Yeah, I think it's definitely hard to find that balance of like fostering innovation and competition and access to care and pricing at the cost of our patients. I don't see a lot of other questions, so we can always end the session a little bit early. I'll let you have any closing remarks that you would like to say, but I do want to thank you for the session today, Dr. Doucette-Sina, for such a thought-provoking discussion, and we're really grateful that you were able to join us. Um, Thank you, everybody else, for being here and for everything that you do for the behalf of our patients. We do hope you will choose to become official DFA member. Um, and please watch out for other additional opportunities to engage with DFA. We do have a national leadership conference that we're doing in June 6th to the 9th in Washington, D.C. The registration link will be shared in the chat. And then there will also be a survey in the chat for CME credit as well. Dr. Dudasina, if you have any other remarks, please feel free to share. Thank you.
Well, I just thank you very much for your advocacy and enthusiasm and support of patients and having the best access to care that they can. It's been a pleasure being able to join you tonight, and I look forward to seeing more great work out of your organization.
Have a good night, everybody. Thank you.
Bye, everyone.